Dr. Priyadharshini PV. Okay, go ahead.
Yes, sir. Now I will be discussing about diagnostic insights into Abducent nerve palsy at a tertiary eye care facility in South India. While learning about Abducent nerve palsy and its etiological aspect is important because it has a very long intracranial course and hence it is more prone for injury at multiple sites. The incidence is around 11.3 in 1 lakh population and it can be unilateral or bilateral, congenital or acquired, and complete or partial. The pathogenesis involves lesion anywhere along its course from pons to the lateral rectus, which results in impact abduction and incontinent esotropia. Immediate evaluation is important since timely diagnosis and management aids in better prognosis. The investigations include random blood sugar, glycosylated hemoglobin, blood pressure, lipid profile, erythrocyte sedimentation rate to rule out inflammatory causes, and MRI brain to rule out space occupying lesion, and MR angiography to rule out vascular lesions such as aneurysm or thrombosis. The management involves treating the underlying causes such as diabetes mellitus, hypertension, raised intracranial pressure, or infection. The supportive care therapy involves eye patch or prism glasses to alleviate the symptoms of diplopia, and medical therapy involves steroids in case of inflammation and botulinum toxin in case of contracture of its ipsilateral antagonist muscle. The surgical correction is usually indicated when there is persistent diplopia or restriction of extraocular muscle movements for more than 6 months. The rehabilitation therapy involves eye exercises. The purpose of my study was to elucidate the clinical characteristics and etiological diversity of Abducent nerve palsy at a tertiary eye care facility in South India. And it was a retrospective study done in Department of Neuro Ophthalmology, and it was done for a period of 1 year. A total of 601 patients were included in the study, and all patients presenting with sixth nerve palsy were included in the study, and patients with infantile esotropia, spasm of medial rectus, and Duven's retraction syndrome were excluded from the study. Considering the gender distribution in patients with sixth nerve palsy, it has been found that majority were males compared to females with an incidence of about 62% in males and 38% in females. Epidemiological analysis showed that sixth nerve showed an age-specific stratification with more than 80% of the population presenting more than 40 years of age. The subgroup analysis showed that 50 to 60 year subgroup and 60 to 70 year subgroup contributed to nearly 60% of the total cases, that is nearly two-thirds of the total cases. Since sixth nerve it has a very varied and wide diverse etiological spectrum, it has been found that ischemic cause is more prevalent compared to all other causes with an incidence of around 72% in ischemic causes, followed by inflammatory, space occupying lesion, trauma, false localizing sign secondary to idiopathic intracranial hypertension, infective, vascular, and demyelinating lesions. It has been found that 94% of the cases were unilateral compared to bilateral, which has a proportion of about 6%. Among the unilateral cases, again, ischemic cause is more prevalent than all other causes with a proportion of about 74%. And among the bilateral causes, again, ischemic cause, it predominates over all other causes with a proportion of about 33%. Metabolic comorbidities were found in significant proportions in patients with sixth nerve palsy, with 21% in diabetes mellitus and 12% in systemic hypertension. I would like to summarize by telling that a total of 601 patients were included in the study with an age group of 51 plus or minus 14 years, and majority were males and unilateral. The most common etiology identified was ischemic cause, and among them 74% were unilateral and 33% were bilateral. 7 cases of demyelinating lesions were found, which were due to multiple sclerosis causing a partial sixth nerve palsy. And the first picture shows a right nasopharyngeal carcinoma invading the right clivus causing isolated sixth nerve palsy. And the second picture shows a nodular enhancing lesion in the left sixth nerve secondary to schwannoma. I would like to conclude by telling that the prognosis and the natural course varied depending on the etiology. Patients with sixth nerve palsy have causes other than idiopathic or microvascular etiology than expected rates. We must also bear in mind that patients under the age of 50 years with sixth nerve palsy and in the absence of microvascular risk factors, neuroimaging, especially MRI with MR angiography of the brain, should be considered. Considering the incidence of space occupying lesion in the sixth nerve palsy, and since sixth nerve is also known as the tumor nerve, it is better to do neuroimaging in all patients with sixth nerve palsy. Thank you.
Which aneurysm do you consider important for your sixth nerve palsy?
Sir?
Which aneurysm do you consider is important? Because you have done MRA, but
Yes,
it was
sir.
a retrospective study of 601 patients. That means each and every patient has undergone MRI with MRA.
Yes, sir.
But you have not written about the contrast. Because you have shown nasopharyngeal carcinoma
Yes, sir.
and other one is your
Schwannoma, sir.
schwannoma.
Yes, sir.
So, but you have not ordered MRI with contrast, but you ordered MRI with MRA. So, all the 601 patients have undergone MRI with MRA? Because I don't think a MRA is needed in 6 now. Even if the microvascular complication
Yes,
is
sir.
there, ischemic is there.
So considering the
which aneurysm do you consider would be causing 6 now paralysis? Or
either
palsy?
posterior cerebellar artery aneurysm or anterior inferior cerebellar artery aneurysm can cause
Posterior
6.
cerebellar artery aneurysm.
Yes, sir.
Okay. What about your ICA aneurysm? I can think of ICA aneurysm in the cavernous sinus that would be causing your third nerve
Intrapetrosal
and then
segment
your
of
other
internal
nerve,
carotid
but
artery, sir.
not isolated 6 now palsy with any aneurysm.
Intrapetrosal
Reason for
segment.
asking this question is why they have unnecessarily been subjected to MRA. If you have ordered MRI with MR or with contrast, then it would have been okay. And
Sir,
601 patient MRA, because it takes another 15 to 20 minutes to do the MRA.
Sir, we didn't do neuroimaging in all patients with sixth nerve palsy, sir. Considering the patient is more than 50
Because
years.
you have not written about that, ki the all patient have not undergone MRI with MRA. You have not written. That is the reason I'm asking. Because it's a huge number, na, 601.
Yes, sir.
So, you said in the conclusion, prognosis depends on the etiology.
Yes, ma'am.
So, what did you do in the study that made you say this? What was the prognosis that you checked?
Considering the patient age group, ma'am, when the patient is more than 50 years and when there is any metabolic comorbidities which has been associated, we initially observe the patient and we used to call the patient after 1 month, ma'am. When the symptoms are improving, then we will follow up the patient for another 3 months, ma'am. And if there is no improvement of the symptom which is noted at that time, then we will indicate neuroimaging in such patients, ma'am.
No, because in your conclusion you said outcome.
Yes, ma'am.
So, you have to have some outcome, no? You must have checked something.
Yes, ma'am.
Did you check the vision?
Mostly
Did you check the
patients-
deviation?
Yes,
What
ma'am.
did you check?
Mostly patients with microischemic causes, they improved, ma'am. But patients who were presenting with traumatic sixth nerve palsy, they didn't show significant improvement, and there is persistence of diplopia, and also there is restriction of extraocular movements beyond
So,
6 months,
that
ma'am.
you have to add. How much did the deviation improve? What was the improvement? That has to be added to come to that conclusion.
Yes, ma'am.
Thank you.